How well can artificial intelligence do an anesthesiologist's job? And how worried should I be about my job security? My name is Max Feinstein, and I'm an anesthesiology resident at the Mount Sinai Hospital in New York City. And in this video, I'm going to be investigating how well ChatGPT does at responding to common questions that are asked by patients, anesthesiology residents, and also surgeons. If you find this video interesting or helpful, I'd really appreciate it if you liked it and subscribed to the channel. Let's dive in. It's not uncommon to hear a seasoned anesthesiology attending say that they can teach a monkey how to do X, where X might be any sort of procedure like an IV placement, an intubation, or an epidural, for example. The emphasis is on knowledge, where anyone with enough experience could intubate a 95-year-old who's getting ready to undergo a pinning for a hip fracture. But the real challenge is in determining whether it's more appropriate for this patient to undergo general anesthesia with an endotracheal tube, or neuraxial anesthesia with a spinal or an epidural, or whether it's just not appropriate to be subjecting a 95-year-old patient with multiple comorbidities and 3-vessel coronary artery disease to any type of surgery like this to begin with. With the proliferation of easily accessible and very powerful artificial intelligence like ChatGPT, the question becomes, how much value is there in the knowledge base that an anesthesiologist builds by going to college for 4 years, then going to medical school for 4 years, and then going to residency for 4 years, and perhaps subspecializing in something after that? To answer that question, we'll need to see how well ChatGPT stacks up to a 4th-year anesthesiology resident, i.e. me. While I do strive for factual correctness in my videos, I should point out that I'm sitting next to a Vinci surgical system. This is not a piece of artificial intelligence, it's just a surgical instrument, and it doesn't have anything to do with anesthesiologists, and it's not part of this video at all. It just happened to be a nice prop in the operating room. For this video, I'm going to be using my laptop in order to access ChatGPT. It's very commonly the case that patients don't meet their anesthesiologist for the first time until the day of surgery, and even the hour right before surgery occurs. And so one of the places where artificial intelligence might have the potential to be helpful for patients is by answering questions about anesthesia more than a day in advance of the surgery. And it's very often the case that questions that patients have are really anxiety-inducing, like whether or not they'll be aware of anything and what they can expect in terms of the actual anesthesia plan. So let's dive right in and ask some of the most common questions that I receive as an anesthesia resident. For example, will I have a breathing tube for my hernia repair? The use of a breathing tube during hernia repair surgery will depend on the specific circumstances of your surgery and the preferences of the surgeon performing the procedure. In general, hernia repair surgery is typically performed under general anesthesia, which may involve the use of a breathing tube to assist with breathing during the procedure. However, certain types of hernia repair, such as laparoscopic or minimally invasive procedures, may not require the use of a breathing tube. I recommend speaking with your surgeon to get more information about what to expect during your specific surgery. So first of all, I have to just say I appreciate the deflection away from giving actual medical advice and encouraging people who are using this to talk to an actual human physician. I will say that there are some accurate parts of this answer, but it is not totally correct and is a little bit concerning. So it is true that a hernia repair is often performed under general anesthesia, which may or may not require the use of an endotracheal tube, and that really depends on the anesthesiologist and the surgeon and the patient and the plan that everyone comes up with. This does say that certain types of hernia repair, such as laparoscopic, may not require the use of a breathing tube. Let me assure you that not using an endotracheal tube for laparoscopic surgery is a pretty bad idea that has a much higher risk of a pulmonary aspiration that could potentially be deadly for a patient. So there is basically no anesthesiologist that is going to agree to doing a laparoscopic type of any kind of surgery without an endotracheal tube in place. So overall, the quality of this answer is questionable at best and ultimately would be misleading for a patient. Let's try to give it a second chance here and see if it can do better. Here's a question that frequently comes up, and with good reason. Is there any chance I will be aware during my surgery with general anesthesia. It is extremely rare for a person to be aware during surgery while under general anesthesia. General anesthesia is intended to cause a state of deep unconsciousness and muscle relaxation during surgery. An anesthesiologist will administer the anesthesia and continually monitor your vital signs and level of consciousness during the procedure to ensure that you remain in a state of deep unconsciousness. It is possible for awareness to occur during general anesthesia, but it is very rare and mostly reported in certain type of surgeries such as cardiac, obstetric, or trauma cases. In such cases, the anesthesiologist will adjust the anesthesia accordingly. However, it's important to note that even if awareness does occur, the patient will not feel pain or remember the event afterwards due to the amnesia-inducing properties of general anesthesia. Okay, again here, there is some factually correct information, but there is also some extremely important factual incorrect information that was presented here that would be very concerning to me if a patient were seeing this prior to receiving anesthesia. Things that ChatGPT got right here include some of the specific types of surgery that are higher risk for intraoperative awareness, cardiac, obstetric, and trauma cases. That's definitely true. But very concerningly in this answer is the fact that there's reassurance provided that if awareness does occur, that a patient will not feel pain or remember the event afterwards. Unfortunately, in a very small number of cases, if there is awareness, there may be associated pain and there may be recall afterwards, because while most of the anesthetic agents that we employ do cause amnesia or blocking the formation of new memories, it is possible that someone does remember something. While it is nice that Dr. ChatGPT does try to provide some reassurance for patients, this is a misguided attempt that provides factually inaccurate information, which I wouldn't want my patients to see if they were coming in for surgery. All right, so maybe third time's a charm. Let's try another question that I'm commonly asked as a resident and see if ChatGPT can do a better job of answering it. How likely am I to experience nausea or vomiting after my hernia repair surgery? Nausea and vomiting are common side effects of anesthesia and surgery. The likelihood of experiencing these symptoms after hernia repair surgery can vary from person to person, but it is not uncommon. Factors that can affect the likelihood of experiencing nausea and vomiting include the type of anesthesia used, the length of the surgery, and the individual's sensitivity to anesthesia and surgery. However, there are several measures that can be taken to prevent and manage nausea and vomiting after surgery. These include medications such as antiemetics, which can be administered before, during, and after surgery to prevent, reduce nausea and vomiting. Proper positioning and breathing techniques during surgery, slowly resuming eating and drinking after surgery, avoiding certain foods and odors that may trigger nausea. It is important to discuss the concerns with a doctor. Okay, so this is an okay response. It includes some information that, to be honest, I've never encountered before. And importantly, it does not include some information that I think is a vital part of an answer to this question that an anesthesiologist would provide. It is definitely true that there are a lot of different factors that play into whether or not a patient will experience postoperative nausea and vomiting, or PONV for short. The factors that are stated here include the type of anesthesia used, which is true, and specifically the use of an inhaled anesthetic agent like isoflurane or sevoflurane does slightly increase the likelihood of PONV compared to the use of a total IV anesthesia based on propofol. But it's really important to point out that an answer to this question is not complete if it doesn't take into consideration some of the other very important risk factors, which include the patient's age. What type of surgery is taking place is also an important factor. And I don't know that describing an individual's sensitivity to anesthesia and surgery is the right way to just frame whether or not a patient has a history of PONV. The next part of the answer, I didn't actually ask for any information about preventing or managing PONV, but it gave it to us anyway, so we'll just take a look. Medications such as antiemetics, yes, it's true that they can be administered before, during, and after surgery. Proper positioning and breathing techniques. I don't know which breathing technique or for whom they're talking about. Should the anesthesiologist have a proper breathing technique? Should I be trying to monitor my own breathing to make sure that I'm focused and administering the right medications? I don't know. And as far as I'm aware, there's not any sort of ventilator setting that's associated with an increased or decreased risk of PONV, so that's a weird part of this answer. Slowly resuming eating or drinking after surgery or avoiding certain foods or odors. I haven't encountered any literature that describes that. Intuitively, I guess that makes sense, but that's just not really a part of the conversation that comes up in real life. After having asked Dr. ChatGPT 3 questions that I commonly receive as an anesthesia resident, I would say that the answers leave quite a bit to be desired. While there is some factually correct information in the answers that I received, there is a concerning amount of factually incorrect material that's been included here, which at this point doesn't really make me scared for my job, at least as far as patients are concerned. But now why don't we check out whether Dr. ChatGPT could be my attending anesthesiologist and answer questions that a resident might need to figure out, particularly towards the beginning of their training. Before we get too far in this part of the video, I should point out that while there is not a fully functional artificial intelligence system that does the role that an anesthesiologist does, there are some systems in place that automate certain parts of the anesthesiologist's job. For example, there are target-controlled infusion systems where an anesthesiologist programs in the parameters that they would like for their infusion, for example, propofol, and then an algorithm takes into consideration some of the patient characteristics that have been inputted to come up with the exact dose of medication that should be delivered. I'll point out for the Americans that are watching this video that this is not actually a system that's used in the United States, but it is used in most of the rest of the world. There are also other types of closed loop systems that have attempted to automate a lot of what anesthesiologists do, but at least at the point that this video is being made right now, none of those are in widespread use throughout the world. Anyways, let's dive right in with a question that a very junior anesthesia resident may be very interested to know the answer to. What is the best anesthetic plan for a laparoscopic cholecystectomy? The best anesthetic plan for laparoscopic cholecystectomy will vary depending on the patient's medical history, comorbidities, and the surgeon's preference. However, a common approach is to use general anesthesia with the patient in a supine position. That's absolutely true. In fact, it would be wild to do a laparoscopic cholecystectomy without a patient under general anesthesia. It would also be basically impossible for a surgeon to access the patient if the patient was not in supine position, meaning laying on their back. This allows the patient to be fully unconscious during the procedure and for the surgeon to have optimal access to the patient's abdominal cavity. It's true. Other options include spinal or epidural anesthesia, which can provide a level of analgesia to the patient but may not provide the same level of muscle relaxation as general anesthesia. So I think that my attending would look at me like I was nuts if I recommended doing neuraxial anesthesia, namely a spinal or an epidural, for a patient undergoing a laparoscopic cholecystectomy. While it would be technically possible to do that, it just doesn't make any sense because you're still going to need to induce general anesthesia and insert an endotracheal tube, which basically entirely negates the point of doing a spinal or an epidural to begin with. So honestly, this is not a good anesthetic plan. All right, well, maybe instead of doing such a high-level anesthetic plan, we can just dial into some specific questions about, I don't know, medication dosing. Let's go with something very common, like what is the induction dose of propofol for general anesthesia for a healthy 20-year-old man undergoing a laparoscopic cholecystectomy? The induction dose of propofol for general anesthesia in a healthy 20-year-old male undergoing a lap chole is typically in the range of 2 to 2.5 milligrams per kilogram. That's true. However, the ideal dose can vary depending on the individual patient and their response to the drug. It's also true, but doesn't provide a lot of guidance for me. Keep reading. It's important to note that the induction dose should be titrated against the patient's response to the drug, and the patient's vital signs, such as blood pressure and heart rate, should be closely monitored during the induction process. Additionally, the use of propofol should be done under the guidance of a qualified anesthesiologist who can make adjustments as needed. So, while all of this is technically true, it doesn't take into consideration some of the important nuances that come along with inducing general anesthesia. Namely, what other agents am I going to be using when I'm inducing general anesthesia in my patients? Very frequently, if I'm doing this particular case, a laparoscopic cholecystectomy, for a healthy 20-year-old patient, while I might be in this dosing range for propofol, that would only be including other medications that are administered, like fentanyl in the 2 to 4 micrograms per kilogram range before this is administered, and most likely also administering midazolam. If I don't administer fentanyl and midazolam before giving this induction dose of propofol, then I will need to significantly increase the amount of propofol that's being administered. I would also point out that it is true that generally speaking, we titrate medications based on a patient's vital signs. When it comes to the induction of general anesthesia, for this particular kind of case, I'm not really looking at the vital signs to dose my medication. I'm taking into consideration the other factors that I just mentioned to come up with my overall dose. But I guess you get an extra little golden point here for saying that propofol should be done under the guidance of a qualified anesthesiologist, which in the unfortunate case of Michael Jackson, propofol was being administered by someone who was not an anesthesiologist, and that had a very unfortunate outcome. All right, let's see if we can make this answer a little bit more nuanced depending on patient characteristics that might be more reflective of a patient who's coming in for surgery at a major academic medical center like the one that I'm at right now. What is the induction dose of propofol for general anesthesia for a 90-year-old woman with 3-vessel coronary artery disease undergoing a laparoscopic cholecystectomy? The induction dose of propofol for general anesthesia in a 90-year-old woman with 3-vessel coronary artery disease undergoing a lap chole may be lower compared to a healthy-year-old male. Maybe. Definitely is going to be lower. Because of the patient's age and underlying cardiac disease, the anesthesiologist should take extra care to minimize the risk of cardiac complications. True. A lower dose of propofol, such as 1 to 1.5 milligrams per kilogram, may be used to minimize the risk of hemodynamic instability. Reasonable. It's important to note that the induction dose should be titrated against the patient. Okay, yeah, all right, we've heard that before. But I like this addition. And make sure to have monitoring in place to detect any cardiac complications. So that's absolutely true. And while this doesn't specify what that would look like, it would be pretty typical to place a pre-induction arterial line in a patient such as this one who's undergoing many different types of surgery. It's also important to consider other factors such as a patient's overall health status, any other comorbidities, and to consult with the patient's cardiologist if necessary. Okay, so those are true. Is this answer technically accurate? Yeah. Is it thorough enough for me to be making an anesthetic plan based off what I'm reading here? Absolutely not. So if this were going to take the place of an anesthesiologist, it would have to tell me what exactly I would need to do for cardiac monitoring, specifically using an arterial line. And again, while it does provide some overall guidelines for weight-based dosing for propofol, it doesn't contextualize it by discussing whether or not any other medications are being used during the induction, which plays a huge role in determining what the weight-based dosing of propofol would be for this plan. Well, not doing great so far, but why don't we ask it what's gotta be the most important question that an anesthesiologist could ask? Will artificial intelligence replace anesthesiologists someday? Artificial intelligence has the potential to assist anesthesiologists in their work. However, it's unlikely that it will replace them entirely. Well, that's reassuring. Anesthesiologists are responsible for the safety and well-being of patients during surgery, and they make decisions based on a variety of factors, including the patient's medical history, current condition, and response to the anesthesia. AI can provide valuable information and insights, but it is not able to replicate the expertise and judgment of an experienced anesthesiologist. AI systems can be used to alert anesthesiologists to changes in a patient's condition or to identify patterns or trends that may indicate a problem. It can assist with drug dosing, monitoring, and prediction of adverse events. While AI technology is advancing rapidly, it will likely take a long time before it is advanced enough to replace anesthesiologists. It's important to remember that AI is a tool that can assist human professionals, not replace them. It will be used to enhance the capabilities of anesthesiologists and make the job of anesthesiology safer and more efficient. This is an answer that I completely agree with. In fact, it's already the case that a number of computer automated events are very helpful for guiding anesthesiologists to provide safe care for patients. For example, alarms that I can set on my ventilator or different monitoring devices help me keep a patient's vital signs in an appropriate range, or depth of anesthesia in an appropriate range for the surgery. And in this video, I've shown that AI can provide some valuable information and insights, particularly by efficiently going through existing research. It is not able to replicate the expertise and judgment, and I think that's really the operative word, of an experienced anesthesiologist. Of course, this video wouldn't be complete if we didn't ask some of the questions that surgeons commonly ask me. So let's find out how Dr. ChatGPT does with this common question of, is the room ready? And can I start operating? As an AI, I do not have the ability to check the room or to confirm if it's ready for surgery. You can imagine that AI that can check the room and tell the surgeon whether or not they can actually go back and start the surgery would have a lot of utility in the real world. This is saying that checking the room is the responsibility of the surgical team and the anesthesiologist. I gotta give ChatGPT credit here. That's definitely true. If you like this video, you might want to check out this video where I show you what an actual human anesthesiology resident does for 24 hours while on call. Thanks very much for watching. I'll see you next time.